All right, so diarrhea. So we're going to talk about stage 6 and 7. 7 is really our diarrhea zone. There's a liquid stool, right, non-formed, and we have options for this. We can, if it's not infectious, or maybe if it is, if it is infectious, we're not going to be giving antidiarrheal medications. If it's infectious and diarrhea, we can still use a fecal management system, an FMS, to manage our diarrhea, because it can, it leads to skin breakdown, which is moisture associated, or incontinence associated dermatitis. So we have options for that. So we'll talk about incontinence and such, and we'll end with C. diff, right? And we'll talk a little bit about the ICU concerns when you have diarrhea. Obviously, the concerns are you're losing electrolytes and fluids, so we got to replace those and be alert to that, right? So 4 was great. We came from the constipation lecture before. We talked about really hard stools, stools that were, can cause obstructions and such. Now we're talking about diarrhea. So there are different types, right? Like I said, the first priority, whatever type it is diarrhea, you'll be losing fluid and electrolytes. So we have to replace those and make sure we are not just replacing water like an outpatient. Make sure you're replacing Gatorade, even though Gatorade is now not a ideal electrolyte solution. But either way, we're not giving antidiarrheals if they have something infectious. We want the infection to leave the body. That's why they have diarrhea, is because there's something that's irritating the bowel lining, that being bacteria, right? It could be viral, it could be other things too, parasitic and such, but we primarily want to get rid of that stuff. We might culture it, we might do ovum parasites, might do all kinds of fancy things to assess what the infection is, right? We know about C. diff testing, for instance. It's something we can test for, right? To see if there is something that we need to fix, right? C. diff has antibiotics we can give, and there's different management we can do for different types of infectious diarrheas. A lot of infectious diarrheas don't make their way to the ICU. It's usually C. diff is the only one that will make it here, right? Even as like an outpatient or being admitted, may have to be really elderly or really debilitated for them to be admitted with a traveler's diarrhea, for instance. All right, so we want to find the cause and fix that. Probiotics might be given after antibiotic therapy, not concurrently, not beforehand. It's usually given afterwards, is where the evidence is. And once they finish an antibiotic course, then they can go ahead and get probiotics afterwards to avoid any kind of diarrhea post antibiotic therapy. All right, so acutely, it's usually a pathogen that caused it. You can have chronic diarrhea from like C. diff, for instance, right? And usually that means you need to get more therapy or you're on therapy. But for the most part, usually acute diarrhea is something infectious, something bacterial is the most severe, right? We have E. coli that's our resident bacteria in our gut that is responsible for a lot of different diarrheas, and there's certain diarrheas that are hemorrhagic, that cause bleeds. We'll point those out in the next slide, but the acronym is SEXY. So SEXY diarrhea is ones that cause hemorrhages. All right, so we'll look at those. But either way, we're looking to see, is it watery? Is it fatty? Is it inflammatory, right? So is it watery? That means there's something osmotic that they're taking that's pulling fluid into the bowel. And it could just be as simple as them taking a laxative, right? Taking some PEG, right? PEG is our Miralax, right? It could be something as simple as that, right? Or it could be that they really, really like cheese. They really, really like ice cream. So there's lactose, right? Lactose intolerance is a form of diarrhea. And chronically, it could lead to problems. They just got to make sure they're replacing their lights. No one gets admitted to the ICU with lactose intolerance. But we have other secretory, not secret ones, but secretory, where our bowel is secreting different things into the bowel that's not really pulling osmotically, but it's making the bowel move faster. For instance, there's like little different colitis, infiltrative diseases and such. Hyperthyroidism is an example. Bile salts can do it. So this is way we can tell the difference between water diarrhea is we could actually do a stool osmotic gap. We'll talk about osmotic gaps for ingested alcohols with acute kidney injury. We'll talk about it then, but basically you're looking at what is the osmolar expectation of the stool and where compared to normal, right? So if there's a gap, that means there's something osmolar that's pulling fluid into it, right? So usually if there's nothing osmolar like a glucose or lactose or sucrose that's pulling fluid, then it should be the normal osmolarity of stool, which is 50 to 100. But if we have something osmolar in there, that gap is going to be higher. So it's based on what we calculated versus what was measured. And we'll revisit this when we talk about like ingested alcohols. like ingested antifreeze, for instance. Antifreeze is, polyethylene glycol is polyethylene glycol Miralax. Ethylene glycol is antifreeze. And if you ingest that, it's going to start pulling fluid, into your bloodstream, pulling water, I should say. And it's going to make your bloodstream very, very, very dilute. We don't have a blood test that measures ethylene glycol. We just know that it's present. There's something there that's pulling fluid, all right? Based on what we calculated versus what's measured, that's a gap. Okay, just like when we talk about anion gaps. And again, we'll talk about that more with the kidneys. And then we have functional reasons. So we had IBS for constipation. You have IBS for diarrhea as well. It has 2 different varieties, right? And again, they're going to have a normal osmotic gap. They're not going to have any kind of difference. There's nothing pulling fluid into the bowel, making it have diarrhea. It's just that they have an enteric nervous system that is overactive. Okay, and then we have fatty reasons for diarrhea. So they have basically a malabsorption, maldigestion problem where their fats are not getting digested. So we'll talk about pancreatitis, specifically chronic pancreatitis, and they are not able to produce the enzymes like lipase to break down the fats in the bowel. So then therefore the fats don't get absorbed, and then you get fatty steatorrhea diarrhea is classic for chronic pancreatitis. Steatorrhea for like Crohn's disease, for instance, they have a inflammatory process in their small bowel, and they can't absorb the fats adequately. So they get a steatorrhea, or a fatty floaty stools. So pancreatic enzymes, especially with chronic pancreatitis, can help as a option for them. And then inflammatory. So that's where we're going to be going with C. diff. So inflammatory is where you have inflammation of the bowel because of an infection of some sort, right? We have an infection with, colon cancer can do it, but radiation, for instance. But we have a bacterial invasion of some sort that's impairing the absorption of water, for instance, right? Where do you absorb water the most? In your large bowel or small bowel? In your large bowel, right? And you have C. diff colitis, you have inflammation of your colon, right? And that's that's the last stop before you absorb water. And that doesn't work because it's inflamed and it has a coating with pseudomembranes. It's not going to work good. So you're going to have water diarrhea because of that. Okay? So what is diarrhea defined as? It's defined as more than 3 stools in a day, or it's more than 300 cc's of fluid is an example of someone who has diarrhea. Okay, we have to pay attention to that, especially like lactulose therapy, right? Lactulose is one of our laxatives that we give for what kind of patients? Yeah, cirrhotic liver patients, right? To reduce the ammonia, to prevent the ammonia from getting absorbed. It disrupts the balance of ammonia absorption in the liver, in the gut. So, but by the same token, it's also going to be pulling fluid, right? So that's something that we have to be alert to when we're giving lactulose. We're inducing diarrhea on these patients. So usually we say hold if more than 6 stools in a day, or 6 or more stools in a day, then we're going to hold lactulose. So we're inducing diarrhea. We know it's going to cause 3 to 6 stools per day. So diarrhea in the ICU. So what does the diarrhea in the ICU look like? So we're looking for an underlying cause of some sort, right? So tube feeding, if you talk to a dietary specialist, a nutrition therapist, they're going to swear up and down that feeding doesn't cause diarrhea, but then they secretly change the order to another feeding in the meantime. It might just be the protein content or the glucose content, but feeding can be a reason for it, right? And it can increase the fiber if need be, which is what they're doing. They're increasing the fiber content of the formula versus what was there before, so that we can avoid we can increase the bulk of the stool, and it can hopefully improve the absorption as well. All right, so these feedings can be highly osmotic. If they're impacted, that's the flip side, right? So impaction can present with diarrhea, so we got to make sure they're not impacted, and that's not the reason. And if it is the reason, we have to disimpact. If is it drug related? Is it because they're on lactulose? Is it because they're on a medication that is dumping fluid too fast from the stomach? We described earlier that metoclopramide and erythromycin only increase gastric emptying. They don't technically increase the peristalsis. So a little question mark there. And then life-threatening causes. Do they have ischemia of some sort? Do they have C. diff? Do they have, how would you know this? How they know they have C. diff? They have elevated white count. their SNS is firing off because of an infection, they're tachycardic, tachypnic, diaphoretic, lactate might be going up, worst case scenario, and your white count will be going up as well. And this tells us that we might have C. diff at hand if we have infectious diarrhea. There's such thing as gastroenteritis, right? So we have a enteritis, inflammation of the intestines, and that could be the reason why they have a fever and white count. Doesn't lead to sepsis and septic shock as much as C. diff, not as much, but it is possible. All right, so as we mentioned, right, we're trying to avoid cathartics unless we completely ruled out something infectious, right? So in a C. diff, they're having stools like up to 12 times per day. They're going to beg you for antidiarrheals, but we have to toughen it out. We have to increase fiber, do all the other non-pharmacological things before give a course of antibiotics before we would consider that. All right, so we look to see, what kind of electrolyte replacement we can do, fluid replacement we can do. Is there impaction? Do we need to disimpact, right? And then cathartics is only if we've ruled out C. diff and we've made sure there's nothing causing the bacteria that's infectious, because we don't want that infection to stick around for longer and grow more. Okay, as we'll learn with C. diff loves to procreate in the large bowel, and it forms a little membrane over itself. It makes a little tent. It's going camping, and it's going to make a lot of more C. diff if we don't get rid of it with antibiotic therapy. All right, so we talked about osmotic reasons. We talked about secretory reasons, motor reasons. There could be just the bowels don't have good motor activity, and that could lead to. It could be to bacteria, or it could be to even like a gallstone gallstones can shut down the bowels. But it's irritation. It's something irritating in the GI tract that's increasing motor activity, and that could be like a variety of IBS, for instance, right? Or diarrhea variety, the diarrhea type. So incontinence, right? So incontinence is due to a inadequate ability to handle our bowels or urine, but here we're talking about bowels, right? So they lost voluntary control because they had a motor dysfunction, a spinal cord injury, right? They had spinal swelling or spinal cord swelling that led to incontinence. Or it could be someone that is, they have too much stool burden and they can't make it to the toilet in time, right? So, there could be local neuron damage. There could be, the external sphincter is just overwhelmed, and we talked about chronic diarrhea as well, loose stools that are just associated with incontinence. All right, so how can we manage this in the ICU? So we have a fecal management system, an FMS, right? This guy is used right here, FMS, to manage the fecal or manage the feces. So we're going to be able to use this to avoid incontinence-associated diarrhea, or IAD. So the idea is they have to meet criteria first, right? So there's contraindications and there's indications, right? So we have to make sure they have what? To make sure they have a good rectal tone. All right, so the ringtone needs to be adequate before we go ahead and proceed with putting this in. Otherwise, it's just going to fall out, right? And it can lead to more damage, if anything. Okay, so rectal tone is good. Make sure there's no fecal impaction, because diarrhea can present with fecal impaction. There's liquidy around it. All right, the frequency, it needs to be there. It needs to be usually more than 6 stools, 3 to 5 stools. I'm not sure what it says 3 to 6 right here. So 3 to 6 stools in 24 hours, that's diarrhea. So that's okay. So if you get a report and they say, oh, we changed it 4 times a day, like, oh, that's already diarrhea, right? Then the next question you should ask them is, what's the ringtone, and also what else? What is the consistency, right? So the consistency needs to be a Bristol what? Maybe Bristol 7, ideally. If it's a 6.5, that might fly, but it needs to be liquidy. Otherwise, what's going to happen if it's not liquidy? It's not going to go down the fecal management system. So we need to make sure that that is adequate liquid content, so that we can get a drainage out of it, and it's not going to start backing up, because you could cause impactions with a FMS, with a fecal management system. Okay, so Bristol stool culture might need to be done to make sure that we are, treating whatever the diarrhea is. You don't just put it in there. It's like, oh yeah, I got the diarrhea managed for 10 days. It's like, well, was it C. diff? We didn't check. So we got to make sure that we are assessing the, something that's reversible, not reversible, something that's treatable. Okay, Braden scale is a good indicator if they're bedbound and have incontinence. That's a high need for a fecal management system. Otherwise, you're going to go from early to medium to severe incontinence-associated diarrhea. Okay, and then yeah, there's risk factors as well. But what are the contraindications? So peds, this is not good for peds. If they've had a fecal management system for 29 days already, they can't have another one for another 29 days. That's contraindicated in that case. Otherwise, they're going to have poor rectal tone afterwards. Okay, and then known sensitivity, allergy. We have. They had rectal surgery in the last, I think it's 1 year, right? So last year they've had rectal surgery is a contraindication as well. And they had, what else? Rectal mucosal impairment. They have like ulcerative colitis. They have a inflammatory process that is causing, significant bowel ischemia, I guess ischemia too, but bowel inflammation is not a good indication for this. Okay, and if they have rectal bleeding, that's not a good indication as well. That can worsen bleeding as well. All right, so we talked about different types of incontinence, right? So we have the mechanisms are overwhelmed, or we just can't, they don't have the rectal tone in the first place because of like a spinal cord injury or the like. Okay, so usually, greater than 6, 3 to 6 is like the low end, but definitely more than 6 stools, definitely good time to use a fecal management system, right? It has to be liquid stools, so that's a 7 on our Bristol scale. They have a good ringtone, and for maintenance, we got to make sure that it is clear and flushed every 6 hours. So every 6 hours, we flush it through the flush ports. We got a catheter flush port right there. It says flush in big white letters on it, because if you use the other port, what's going to happen? That's for the cuff to keep it in place, right? And that's not going to be comfortable. All right, so we're going to make sure that we identify the cuff. You check the cuff, right? Maybe on your routine assessment, you're going to check it to make sure that it has the 30 mLs or 40 mLs, whatever the manufacturer says, however much should be in there, so that we have a good, that it's not just going to slip out on us. Okay, so incontinence-associated diarrhea, so it happens because of incontinence, not diarrhea, but dermatitis, because of diarrhea, because of the acid environment of the stool itself. So we want to make sure that we are, cleaning the area as much as possible as soon as the incontinence is present, that we are cleaning it up. We want to make sure we're not using briefs or what was the word, diapers, and what is the word they use, depends. Anyways, they want to make sure we're not using those. They like to use them from home, but we want to have a chucks because we want to have air circulating. We don't want that all wrapped up and locked in, right? The other reason is because of UTIs, right? UTIs are very, very easy to happen if we use briefs. So just a straight chucks is fine, and then we'll be checking to make sure that they are intact or not dirty at least. And then when we wipe it up, we want to make sure that we're using not soap. So not soap and water from the sink. It should be just wipes to wipe it down. There's all kinds of special formulated wipes nowadays that have emollients and other fun stuff in it. Fun stuff in it, and please make sure you don't use it on the floor, right? If something, I guess a stool falls on the floor, or if you're like wipe the floor, your floor has all kinds of speckles on it. Please don't use the wipes that are wiped for the patients on the floor, because those emollients and oils are gonna be on the floor, and you're gonna slip, and that's more paperwork. All right, please don't do that. All right, what else do we need to do? So we need to apply some barrier cream. The barrier cream needs to have zinc oxide. There's a few other options out there, but it needs to have zinc in it. Zinc is going to be the specific deal that's going to be ideal to prevent any kind of further breakdown of the skin. Okay, so it needs to be a paste that's going to be over the site, and between cleanings, you're not going to wipe off all the zinc till you get down to bare skin. It's just wiping off whatever stool is there and just reapplying. So you're not starting fresh, right? Otherwise you're going to take off skin that's trying to heal underneath it. All right, so then what else do we got to do? So low air loss mattresses and mattresses that have airflow, they are going to prevent that dermatitis from developing, because dermatitis is bacteria that are irritating and also that could grow, and also You want the skin to improve when it's not full of warmth. You want to be taking that warmth away, right? Just like with pressure ulcers form, when skin is wet and warm, you want the whole purpose of these air mattresses, yes, for pressure, but also it blows away the warm air and it recycles, keeps the air cool. So there's not a lot of breakdown that might occur. So air mattresses are a good idea. We have the little waffle mattresses that we can throw in the beds to help out with pressure ulcers, but also help out with dermatitis. And what else can we do? So they can develop fungal rashes as well. And the fungal rashes are, fungus loves to grow in warm, wet environments. So hopefully we can avoid that in the first place. But if they do have it, usually we're doing Candida exposure, or it might be Candida, but we're doing like nystatin powders and such to make sure we're, getting rid of the rash as early as possible. All right, so this is how we fix incontinence once it's happening. We can use our FMS to hopefully help the skin repair. Otherwise, in the meantime, we got to make sure that we are, supporting skin regrowth as much as possible. So small and large bowel infectious diarrhea. So we have the small bowel right here in the middle that's getting infected. All right, there's different organisms out there that might do it, but usually the small bowel is what? Is it sterile or non-sterile? It's usually sterile, so it's really hard for bacteria to grow in the small bowel unless the motility has decreased significantly. Because you do intake through your GI tract, right? You do swallow stuff that are non-sterile, right? So that stuff can procreate over time, such as which bacteria that causes ulcers? H. pylori, right? So H. pylori is also something that can grow. It's not going to want to go in the small bowel. It likes in the stomach. It's going to take hold. It's going to start making everything optimal for it to grow, and also it's going to start raising the pH, right? It makes you more acidic. It makes you start secreting more acid to break down the already inflamed tissue that H. pylori has invaded. But also it's going to start making things basic, so H. pylori can procreate and grow exponentially more than it needs to. That's why we give antibiotics and we give proton pump inhibitors for these guys to hopefully eradicate H. pylori. But also the H. pylori makes it great for which other bacteria to grow? For CDAD or C. diff associated diarrhea, right? So this is C. diff is found in the environment, right? And then it's going to make its way through the stomach, and it's not going to get neutralized by the pH of our stomach, and it's going to make its way all the way down to the large bowel where it's going to start taking hold, right? So that's a significant cause of C. diff. Other causes of C. diff are when you give what? Certain antibiotics, right? Certain antibiotics will eradicate all the good bacteria, and then the bad bacteria, such as C. diff, can grow, right? A good portion of the world population, I think it's like 2 to 3 billion, have C. diff already, right? So it's like almost like 40% of just the world population has C. diff at all times. So we got to test appropriately when we talk about C. diff. But it's ready and willing to grow if you knock out the other bacteria with antibiotics, for instance. Okay, so bacteria, they love to feed off and interrupt nutrient absorption. So especially if they take hold like C. diff, it ingrains itself inside the walls of the colon, and therefore that colon is going to be inflamed, and it's not going to do its job. And the job of the large colon or the large bowel, large intestine, is to do what again? Is to absorb what? Absorb water, right? So we're going to have watery diarrhea as a result. As I mentioned, there's certain bacteria that cause bloody diarrhea. So it's important to recognize when we're testing them, do you have bloody diarrhea? We'll do stool for ovine parasites, not really cause blood, but we'll also do stool cultures, okay? And it's usually the first 24 to 48 hours. It's usually useless afterwards in the hospital setting is to look for these things, okay? But usually they had recent travel, they had they had weak immune systems with CMV. They had undercooked beef, undercooked pork, undercooked poultry. All these things put you at risk for fancier versions of E. coli, right? There's different E. coli versions that could cause hemorrhagic conversion or hemorrhage of the GI tract. All right, so those toxins get released, they invade and cause inflammation that damages the mucosa, so water can't be absorbed, and you get that bloody diarrhea as a result. And the inflammation itself has made its way down into the mucosal layers where blood can leak into the GI tract. Okay, so symptoms obviously are, it's going to be a lot of pain, a lot of diarrhea. That's going to be, always filling up the rectum, and they get this sensation where the rectum is not emptied at all times. It's called tenesmus. So they have this urgency and always want to try to make it to the bathroom in time, hopefully. Okay, so again, when you have a large bowel diarrhea, they're high risk for fluid loss. So we got to be alert to those that have, who's at risk for diarrhea. Those are the ones with protonics and H2RA use, so histamine blockers for the gut itself, for the gastrum itself. And why would that put them at risk for diarrhea? If they're on protonics. I thought protonics got rid of H. pylori. It does. Right, it gets rid of H. pylori, but then you just made the gastrum more alkaline, and now C. diff can take hold, right? So also it can make it so H. pylori can take hold also, because H. pylori can weather the environment of the gastrum, which has a low pH. It can go in there and try to and take hold, hopefully. But when it's alkaline, it's like that's perfect for H. pylori to take hold. So it's almost like a double-edged sword, right? That's why we don't do prolonged PPI therapy. We try to cut it off at 30 days, maybe 3 months at the longest. All right, so decreased motility puts you at risk for more infection to take claim. And then again, like red flags would be someone that is immunocompromised, has recent antibiotics. Recent antibiotics put you at high risk for C. diff as well. All right, so 5% of our lower GI bleeds are due to infectious colitis. So we have some infection of our colon that's causing bloody diarrhea. All right, so back to small bowel issues, right? So we got the decreased gastric acid. There's immune reasons. We have dysmotility. We have our small bowel is not going as fast as it should, such as like diabetic neuropathies. We have IBS, other reasons why we might have a overgrowth of bacteria in our small bowel, right? So that can then lead to bacteria translocating through our, they'll grow more, but also the bacteria can translocate from the bowel into the systemic circulation, especially if we have defenses that are impaired, like if we have if we're immunocompromised. Okay, and then if we are impairing the small bowel, well, the small bowel doesn't do fluid, maybe a little bit, but it's more involved with what? What does the small bowel absorb? Nutrients, right? So we're going to have vitamin deficiencies, right? Steatorrhea, such as with our like Crohn's disease, for instance, that's irritating the small bowel. So, and also we get vitamin deficiency. They get more malnourished when they have small bowel diarrhea. All right, so that's the idea behind our different diarrheas.